Welcome. I am Terry Tropin, and today I'll be discussing coding a consultation visit using the new 2023 guidelines for CPT's evaluation and management codes. First, let me tell you a little bit about myself. I have a master's in healthcare administration informatics from the University of Maryland Global Campus, and I have these certifications. I'm also an AHIMA-approved ICD-10 CM-PCS trainer, and I'm retired from teaching at Montgomery College in Maryland. I've also written some books, and here are my books. I have one on evaluation and management coding, one on the CM coding guidelines, and one on the PCS coding guidelines. These books are study guides that summarize the guidelines and translate them into regular English and puts them in tables so that they're easier to access. These books are available on Amazon and are updated every year or as needed. Sometimes they make changes in the middle of the year, and those changes are put into the books. Okay, so this is what I'm going to talk about today. I will present a consultation visit and then go step by step through the process of coding this case. This includes determining the level of medical decision making and then what code would be used if using medical decision making. And then what code would be used if selected using time only. So that's what we're going to talk about today. First of all, what is a consultation? Here is CPT's definition. A consultation is a type of evaluation and management service provided at the request of another physician, other qualified healthcare professional, or appropriate source to recommend care for a specific condition or problem. This means you must have at least two providers involved, the provider who asks for the consultation and the provider who does the consultation. The first provider is often a general practitioner who's asking for recommendations from a specialist. The consultation must then report back his recommendations to the physician who asked for the consultation. So you got to have two people involved. So this is what we're doing, the consultation services. So these are the consultation codes. We have an outpatient consultation, 99242, 99245. Then you have inpatient or observation consultations, 99252, 99255. This case is an inpatient consultation. Now these codes are selected using either time or medical decision making. The time for the codes is expressed in a specific number of minutes, which must be met or exceeded. Oops, sorry. So we're coding an inpatient or observation care consultation. So here are the guidelines related to the relationship between the patient and the consultant. The consultant may not have provided any face-to-face services to that patient during this hospital stay. Of course, the consultant may have seen the patient in a different setting, such as an office. So may not have seen the patient during this inpatient or observation stay. There are also guidelines related to the relationship between the two providers in the same group practice. Now, if they're in the same group practice and they're the same specialty and same subspecialty, you can't use a consultation code. However, if they're in the same group practice but have different specialties and subspecialties, you can use these codes. For example, the requester and the consultant may not be in the same group practice and both be dermatologists. However, the requester and the consultant may be in the same group practice, with the requester as a dermatologist and the consultant is a cardiologist, different specialties. Of course, if the providers are in different practices, it doesn't matter if they're in the same or different specialties. So let's look at the case. Like most consultation cases, this is a little complicated. So the history, this is a 62-year-old white male whom we have asked to evaluate regarding dizziness and a possible new stroke. history of myocardial infarction 2 years ago, coronary artery bypass, hypertension, and diabetes, but it is well controlled. So let's look at more of the case. So approximately one month ago, the patient developed what he described as some double vision. He did see his primary care physician, who felt this may have been due to a diabetic extraocular movement palsy, and the patient was given a patch. After 3 weeks, his symptoms resolved. Around the same time, he noticed some numbness and tingling in his fingertips, which at times still occurs. He was doing fine until this past Saturday, when he had the onset of what sounds like disequilibrium or vertigo, had difficulty walking. This was transient and seemed to resolve. This is not currently a problem for him now, and he is much better. The patient also stated that his son told him he had some slurred speech, but he was not aware of it. So he reported no other specific symptoms. He denies headaches, denies any new changes in his vision in the past week, no other areas of numbness or tingling. He felt like his balance was only off for a short period of time, but then resolved. He denies problems with bowel and bladder function, denies nausea or vomiting, denies any chest pain, palpitations, or shortness of breath. So this is the history that the physician will use to do the appropriate examination and history, which these codes require. So this is what the physician feels is appropriate in this case. So notes reviewed. Notes from the primary care physician from 1 month ago, the one that looked at the double vision, were reviewed. She believes that some of his problems may have been related to recent medication change and felt that otherwise he would be okay. Notes were also reviewed from the admitting physician. This physician noted that the patient seemed to be somewhat ataxic, off balance. Patient was admitted to rule out a new stroke. Okay, laboratory data and other diagnostics. So laboratory data, current blood work on admission showed normal electrolytes. Digoxin was less than 0.3. CPK levels have been normal. White count 11.4 with the remainder of his normal. INR, International Normalized Ratio Clotting Time, was normal. He remained neurologically stable since admission. So the physician ordered an MRI and an MRA for tomorrow. Magnetic resonant imaging and magnetic resonance angiography. Electrocardiogram was grossly suboptimal with an ejection fraction of 35% to 40%. Carotid ultrasound preliminary showed no stenosis. Heparin is on hold. Remember, he had a myocardial infarction previously. Heparin is on hold at this time pending reevaluation and the results of the MRI and the MRA. Okay, medications: glucophage, diabeta, Lipitor, heparin, which has been discontinued. So this is the examination. Remember, appropriate history and exam. So this is the appropriate exam part of it. The patient is awake and alert. He's fully oriented, able to name and repeat. Attention, concentration, and memory are okay. Cranial nerves 2 through 12 are grossly intact. Next is supple with no bruits. Motor exam appears symmetric with no significant focal weakness. There is no tremor. Sensory exam is remarkable for stocking glove sensory loss. That means damage to the large sensory fibers affecting the ability to feel vibrations and touch, especially in hands or feet. Remember, he had that tingling. Reflexes are symmetric and somewhat diminished in the lower extremities. Gait is only minimally wide-based. That means the patient stands and walks with their feet widely apart, which may be an indication of ataxia. But he's able to ambulate on his own without any clear ataxia noted at this time. Coordination testing is symmetric. Rombard test, that's also for balance, is negative, but he does have difficulty with heel-to-toe walking. This is the consultant's report back to the the requesting physician. So the consultant says, impression, the patient presents now with transient vertigo along with some slurred speech. This combined with a recent history of double vision certainly warrants a workup for vertebrovascular insufficiency. This is the arteries that supply oxygen and glucose to parts of the brain that are responsible for consciousness, vision, coordination, balance, all the things that this patient is having trouble with. So recommendations: if the MRI, which the consultant ordered, an MRA and other studies are negative, then treat with antiplatelet therapy. Physical therapy, blood pressure and blood sugar control while avoiding hypotension. Will likely need to stop the heparin or discontinue its use temporarily as long as the studies appear normal. If all of these tests turn out okay and the patient is stable, discharge could be shortly. The documentation states that 80 minutes were spent with patient and reviewing the notes from the primary physician and the requesting physician. So here's all the information. How do you find the code? You need to draw out the important information from a case by underlining the important parts or making notes, and these will help you select the correct code. You don't want to read and reread the case in order to find the correct information. So how do you know what to underline? Well, it takes practice and a familiarity with the codes and guidelines, and once you get more familiar with it, it will be easier to do this, to find the important information. So let's look at what we're going to underline. History, this is all you need to know. Why was he admitted? Possible new stroke. Okay, all of this information, we don't know need to know how old he is or need what race he is. We need to know possible new stroke. That's why he's being seen. So on this page, the information that we draw out, diabetic extraocular movement palsy resolved. Numbness and tingling still occurs. Disequilibrium or vertigo transient. Remember the physician said that in the recommendation that was still a little bit there. Slurred speech, that's a little bit still there also. This is the history, but since everything was denied, we're not going to underline it. This goes towards the appropriate history and physical that the physician needs to document, but for selecting a code, we don't need it. The notes reviewed from other providers is also important. So I looked at notes from the primary care physician and notes from the admitting physician. So this is important. Then we're going to look at the laboratory data, blood work. Other things were normal, digoxin level, CPK, normal. We do need to know that the MRI and the MRA were planned, ordered for tomorrow. They looked at the echocardiogram, which was done, I believe, in the emergency room or at admission by the other doctor. Carotid ultrasound, no stenosis, heparin on hold. So this is important because this is what was ordered by the consultant. Okay, medications. Here are the medications for these patients. For this patient, he's receiving glucophage and diabetic for his diabetes, Lipitor for cholesterol, and heparin, an anticoagulant. These drugs have possible side effects. We're not looking at any of these times. The patient has been on these for a while, so the side effects don't seem like there's a lot of risk at this time. So how do we pick the codes? First, let's look at the medical decision making. So remember that medical decision making has three separate components. Put together, they determine the level of medical decision making. So first you have the number and complexity of data. That's number and complexity of problem addressed. That's what's wrong with the patient and how serious it is, or what may be wrong with the patient and how serious it is. Then you look at the amount and the complexity of data. So that's the data that the physician needs to review in order to find out what the problem is or what's the best way to treat it. How much data does he need in order to, or he or she need in order to determine that. Then you get to the risk of complications and morbidity or mortality. This is the risk associated with the treatment, not the conditions. The risk associated with the conditions is here. The risk associated with the treatment is there. So put these all together and you get the level of medical decision making: straightforward, low, moderate, or high. So let's go step to step through these. Let's look at the first component, problems addressed. So you have straightforward, low, moderate, and high. Straightforward, one self-limited problem. Well, it's obviously not that one. Low, two or more self-limited minor problems. No, this is not minor. Stable acute illness, acute uncomplicated illness. No, that seems to not to be as much. One or more chronic illnesses with exacerbation, progression, or side effects. Two or more stable chronic illnesses. One undiagnosed new problems. One acute illness with systemic symptoms. One acute complicated injury. Yeah, some of that. But then look at high. One or more acute chronic illnesses with severe exacerbation, and then you get one acute or chronic illness that poses a threat to life or bodily function. Okay, that's the key part here. The patient has dizziness and vertigo, and the cause is being investigated. So this is the undiagnosed new problem. So the guidelines for problems addressed include acute or chronic illnesses or injury that poses a threat to life and bodily function. That's down here under high. This may be included in, the guidelines state some symptoms may represent a condition that is significantly probable and poses a potential threat to life or bodily function. These may be included in this category when the evaluation and treatments are consistent with this degree of potential severity. They're not saying the patient had a new stroke, but potentially they do. So you can do this as high even when it's only potential. Doesn't have to be for sure. So therefore, we're going to say problems addressed is at high. So let's move on to the second element. You have low, moderate, straightforward, low, moderate, and high. So for low, review of external notes from each unique source. So remember we had unique sources. We had the reviews from the two physicians, the first physician and then the admitting physician. Review of each unique test, ordering of each unique test. Okay, so we had two unique sources, so you can count each one of those separately. So not an independent historian in this case. Moderate, you must meet at least one of the three categories. So you have external notes, two of those. Ordering each unique test, two of those. So that fits right there. Independent interpretation of tests, no. Discussion of management of test results, test interpretations. Well, writing back to the requesting physician is part of a consultation, so that doesn't talk about a discussion. So remember that independent historian for moderate and high is in category 1. Independent historian is its own separate category for low. So remember those differences. For high, you need meet at least two of the categories. So you have category 1, we've already said that we meet that, but you don't have category 2 or category 3. So therefore, this is moderate. They ordered two tests. They talked to two, they reviewed notes. They reviewed the echocardiogram and the blood test. So all of this goes with category 1. One of the three categories. You didn't have this one, you didn't have this one, so this is moderate. In order to be high level, you'd have to have 2, but there we're not. Okay, so let's look at risk, the final component. So you have straightforward, low, moderate, and high. Straightforward, minimal risk, well, that's not the case. Low risk, that's not the case. So remember, moderate and high do only examples. So prescription drug management, yeah, they're looking at the drugs, kind of monitoring them, but they're not high risk. No surgery, no minor or major, and no discussion of social determinants of health. So let's look at high. Drug therapy requiring intensive monitoring for toxicity. That's not the case here. The patient has been on these drugs for a long time, for a while. They are stable. There doesn't seem to be a problem, and there's no decision for surgery in this case. So based on this, we're at moderate risk. So you take the 3 elements, high, moderate, and moderate. Problems addressed is high, data reviewed is moderate, risk is moderate. Now the guidelines state to qualify for a particular level of medical decision making, 2 of the 3 elements for that level of medical decision must be met or exceeded. So these are the 2 elements that are met, and it doesn't matter that this is high. We're going to do moderate. So based on what we've said, this is medical decision making is moderate. Okay. So what code are we going to use? We've got 99252, 99255. So look at that section of codes in your books and find the one that says medical decision making moderate, and that takes you to 99254. But remember, the physician spent 80 minutes with the patient and reviewing the notes from the 2 other providers. If you're coding by time, that's 99255. 99254 is only 60 minutes, but you can do it by time. And so therefore, of course, we're going to take the bigger code, the more extensive code, because it pays more, 99255. So that's the code we're going to select. That completes this video. If you have questions or comments, please feel free to contact me. There is my email right there. There is my Facebook right there. So remember, I have the books on Amazon, and here is the link to it. It's also in the introduction to this video. You can just go into Amazon Books and type in my last name, Tropin, and this will give you, take you to the books. If you'd like a copy of these slides, give me a thanks and send your email address to me at terry.tropin@gmail.com, and I will send you a PDF of these slides. I hope this has been helpful to you. Thank you. If you're interested in a practice on outpatient coding, look at practice 1. If you're looking at inpatient settings, see practice 2. If you're looking for nursing facilities, see practice 3. So all of the kinds of settings, I have a practice up here for you. For a larger discussion of the E&M coding for 2023, see my other videos, 2023 Evaluation and Management Updates. If you enjoyed this video, please give it a like and subscribe by clicking on the picture in the lower right-hand corner. Thank you very much.